Good afternoon to all. Now for the next few minutes we'll spend on a scenario when we face poor capsular support while planning for secondary IOL, what to do. So pediatric surgical aphakia poses a difficult situation for us to handle and timely refractive correction is required. So for children we face a challenge because we need to preserve their monocular vision as well as we need to provide binocularity, and there's a constant fight against stimulus deprivational amblyopia in these children. So the controversies that exist in this topic are regarding timing of secondary IOL, IOL design, material, methods to be used, what is the site of fixation, and we need to be aware that safety and effectiveness is very essential in these growing eyes. So IOL implantation in pediatric eyes with insufficient capsular support is indeed a challenge. So childhood aphakia occurs in children when the lens is aspirated because of cataract in early childhood, or following a trauma, lens subluxation from hereditary disorders and lens anomalies. So in an optimal setting, when the sufficient residual capsule is left behind after the first surgery, it is a cakewalk. So you can easily place in. As we see in this video, a clear corneal tunnel has been done. 3-piece intraocular lens has been implanted. So initially the leading haptic, then the optic and the trailing haptic is placed in the sulcus. Anterior vitrectomy is performed, pupil is considered and the wound is closed. We don't face such a optimal setting in all the cases. So whenever we have a child who has an insufficient capsular support, we need to decide to place in an altered site whenever they are intolerant to contact lens, aphakic glasses, not performing amblyopia therapy. So the prerequisites for us to consider when we plan for an altered procedure is there should be a complete absence of uncontrolled glaucoma, uveitis, endothelial dysfunction, and there should be absence of retinal problems, and parents should be more motivated and they should be understanding the risk associated with the procedures. So as a preoperative evaluation, child requires visual acuity, retinoscopy, orthoptic evaluation, slit lamp biomicroscopy, IOP, fundoscopy, biometry in appropriate setting. This can be done as a in-office measurement or as a UA technique. So what are the options that is left for us when we face a situation of inadequate PC or a zonular support? So it can be an AC angle supported IOL, iris claw which can be anterior chamber placed or retropupillary placed, iris sutured IOL, or the back can be strengthened further and intracapsular implantation can be done by using rings and segments, scleral fixation towards the end, and it can be either sutured or sutureless. So AC supported IOL, it is no more a desired procedure for the pediatric eyes because of its own complications, because of the size of the angle supported IOL doesn't fit into children, IOL rotations are more common, pigment dispersions and glaucoma, so we do not prefer this site for secondary IOL implantation. Coming on to the next technique, iris claw lens. This can be either anteriorly placed or retrofixated. So technically anterior fixation of iris claw is very easy compared to iris sutured or a scleral fixated IOL. But it has its own complications as denoted in the literature. There's chances of retinal detachment, IOL de-enclavation, needing the requirement to do IOL explantation, pupillary blocks, and increased endothelial cell loss. So this is a study by Barbara et al. In Eye 2016 where they have described a child with an iris claw and they have discussed the case further. This child had ectopia lentis, underwent lensectomy without an IOL implantation. Further, the child was found to be intolerant to contact lens and non-compliant to glasses. Planned for a secondary IOL implantation with artisan aphakic IOL. Child had a good best corrected visual acuity of 6.6. Unfortunately, child had a traumatic unclipping of the nasal haptic, so a repositioning of the IOL was done. So in this child they had found that there was a rapid rate of endothelial cell loss that was encountered after the initial surgery and a re-enclavation event. So we also come across such kind of patients where at 18-20 years of age they had a anterior fixated IOL and presenting with pseudophakic bullous keratopathy who require IOL explantation. So in our center we prefer to place in little older patients retropupillary fixated IOL. We do not prefer iris claw in children. So the advantages of iris claw is it is located in the posterior chamber and it deepens the AC. It is the preferred site where the IOL has to be, and there is less risk of endothelial cell loss. So this is the enclavation which is noted by the enclavation mark on the iris and the claw border. So specialized forceps that grasp the iris claw could be used, and a sturdy spatula can be used for that. So here I am sharing a video of a patient. So the pupil is pilocarpinized, 2 side ports are being made. Through the main tunnel, the iris claw lens is initially inserted vertically and then horizontally placed. Adequate OVD is being placed. Iridectomy has been done. So on the non-dominant side, the surgeon holds the haptic, enclaves the iris tissue through the haptic. Then further OVD is injected, the IOL is positioned, and through on the dominant side, the IOL is held again, and gently the iris is swept over the haptic, and through the side port again the spatula is being introduced and the iris tissue is being enclaved. So good sign of a good enclavation is the pupil becomes oval shape and the IOL is well centered, excessive OVD is being washed and the wound is being closed. So the next technique here is the iris sutured posterior chamber IOL. So we prefer to place and use iris fixation using a 3-piece rigid IOL, and the iris fixation is done with the optic dialing hole. We can use either a 10O or a 9O polypropylene suture. So in this patient, almost 270-degree good capsular support with an iris is seen and had a corneal tear. So here I am sharing this video of a patient who had iris sutured IOL. So this patient has almost adequate amount of capsular support. So initial peritomy, conjunctival peritomy is done. Following that, wet field cautery is applied and a corneoidal scleral tunnel is being created. So 2 side ports are being made and then spatula is being introduced to examine for the support of the capsule. So there is a deficient amount of support seen in this quarter. So we decided to place in a 3-piece IOL and strengthen the IOL stability further with the iris fixation. So a straight needle is passed through the main tunnel, passes through the iris tissue, comes out clear corneally, and through the hypodermic needle a straight needle is passed in with the polypropylene suture. Further it is guided in through the optic dialing hole, received out, and the IOL is gently implanted into the AAC. Then the leading haptic is placed in the sulcus, dialing of the optic, and the trailing haptic is done. And the optic hole is brought in such a position that it lies closer to the initial iris insertion, and the trick is to place at least 6 to 7 throws of sliding knots so that the IOL, the suture knot stays stable and the IOL is also stable. The suture ends are being could be cut with 1R scissors. OVD has to be washed, excessive OVD has to be washed in, and then wound can be closed. So coming on to the next patient whom we planned for iris sutured IOL. Here this patient had a good capsular support but a very weak zonular support. So here we planned to stabilize the capsular bag with hooks, and then further the IOL was the capsular bag was well stabilized using the capsular tension ring. Note that the C part of the capsular tension ring has to lie in the area of maximum zonular dehiscence. Then further corneoscleral tunnel is done, anterior chamber is entered. So as the previous video, after the AC is entered, 26 gauge needle is passed in through the main section, takes in the peripheral iris tissue and then exits out through the clear cornea, and 9O polypropylene suture is engaged in. Here we plan to place in the IOL intracapsularly. So optic and both the haptics are placed. So here again the trailing haptic is faced in the direction where the maximum zonular weakness is, and IOL is further stabilized with the iris suturing. So as my previous speaker Dr. Sandra ma'am, she presented that IOL stability can be done with the haptic fixation also, but literature also shows that the risk with that is there is dislocation of the IOL that can happen. Cases with the iris fixated IOL, intact sutures have been noted, but the IOL haptic rotates out of the sutures. So better case selection is required when we choose for iris sutured IOL, mainly in aphakic eyes. We need to choose eyes with a minimum amount of capsular support and a good zonular support. So not always you will have a case of an iris fixated IOL with a clear visual axis. There can be optic capture, there can be posterior synechial pigment dispersions. So these complications can also be faced in children. Coming on to the next technique of transscleral fixation. Of all the techniques mentioned for transscleral fixation, sutureless scleral fixation is now the more common and preferred technique. The problems with sutured scleral fixation is the suture erosions, IOL getting dislocated, and suturewick endophthalmitis. So the sutureless technique avoids all the problems related to suture. So we prefer to place in and use a 3-piece intraocular lens. So this is a Grishhaber max grip forceps which is used to grasp the haptic. So this is one of a patient where through the sclerotomy the forceps is being inserted, then the intraocular lens is being implanted, and the leading haptic is well grasped with the forceps and externalized. Same way the trailing haptic is also externalized, and the haptic is being tucked into the scleral pockets that has been already created. So both the haptics are being tucked in. After confirming the IOL stability, the wound is closed. So I am sharing this a patient who had a corneal tear and a traumatic cataract aspiration done, who had a very insufficient capsular support. You can see only in the peripheries there is strands of capsule that is left behind. So this child underwent a scleral fixated IOL. So adequate amount of conjunctival peritomy is being made. Following wet field cautery is applied, corneoscleral tunnel is made. So after that the scleral pockets are being made. We prefer to make the scleral pockets 180 degrees apart, at least 90 degrees from the main incision, which is at 12 o'clock meridian. Here a bent 15 degree blade is being used instead of a MVR blade, 15 degree blade. So that helps us to avoid an extra instrument. So here the anterior chamber is entered through a 26 gauge needle that is passed through the sclerotomy wound. The intraocular lens, the haptic is externalized, and the trailing haptic is also externalized, and it is tucked in the scleral pockets. Another patient with scleral fixated IOL here planned as an initial procedure. This is a 10-year-old boy with a microsclerophakia. We wanted to perform lens extraction along with that planned for a scleral fixated IOL. So here I want to just show you the technique which was shown with the previous speaker, how the haptic can be brought out using a 26 gauge needle. So here again 15 blade is used. So 1.5 millimeters from the limbus, the scleral tunnel is being made, length of around 4 millimeters. So following lens extraction, adequate amount of anterior vitrectomy is done. Anterior chamber is maintained through the pars plana route. Here you can note that the 26 gauge needle, bent 26 gauge needle is slowly externalized, avoiding injury to the main tunnel, brought out through the McPherson's, held in, and 4 mm about of the leading haptic is gently threaded into the 26 gauge needle, and slowly it is externalized. Here we could additionally use silicone stopper also, so that we can avoid further slippage of the haptic, because always we will be dependent on our assistant for holding the initial haptic. So any slippage of it will result in lens dropping. Another trick is we can place in a suture through the optic dialing hole, which can also give us an extra stability, so that you don't lose the intraocular lens in the vitreous space when we are trying to manipulate. So the main wound and the scleral tunnel wound has to be sutured after confirming the IOL centration. So this is the patients whom we had performed. So well-centered lens in the ectopia. Here you can see that the haptic is seen through the scleral tunnel. So just before I complete, just want to go through few studies, just couple of studies where they have compared iris claw anterior chamber lens with the iris fixated lens in children who underwent secondary IOL for Marfan's. So Hiroshima et al., they have reported that both the visual acuity and the endothelial cell loss did not differ much between the claw and the iris fixated technique, but there were a higher rate of IOL dislocation with the iris suture technique. Then another study where they compared sutureless intraocular lens versus iris claw retropupillary fixated in pediatric eyes, where they found that both the studies, both the techniques had a comparable visual outcome, but the retropupillary iris claw technique was a shorter procedure and much easier to perform. Transcleral fixation had cases with IOL decentration and ocular hypertension and had an increased endothelial cell loss. So scleral fixation is an option we can consider in patients who have severe iris damage. To conclude, so SFIOL could be considered as an option whenever the child lacks, when we are planning for a secondary IOL, when the child lacks iris and a capsular support. Despite sutureless technique becoming more common, we need to be aware that even with this technique, IOL can still dislocate. Innovation is required, but we need to be more conservative whenever we are suspecting children with glaucoma and there is risk of chronic inflammation. So always, as a basic, visual rehabilitation and amblyopia treatment should never be missed in any of these cases. And long-term follow-up, as a lifetime follow-up, we need to follow in these children, and it is very crucial. These are my references. Thank you so much. I thank Madam for this opportunity.